Thank you very much. Carry on with our symposium, Sérgio Mascarenhas. Now it's my honor to transform our coordinator into speaker. But before that, let me introduce myself. I am responsible for Brain for Care here in the US, developing the business of Brain for Care and bringing the discovery of the professor here to the US. There are 7 ongoing trials. And I was a mentored student. I was a student of Professor Ivone, Sérgio's wife. And for 12 years, we worked as colleagues at the University of São Paulo. So I'm delighted to be here putting together this symposium. Professor Eduardo Colombari is a very well-known researcher in our history and our main partner in understanding the physiology of compliance. And this is the main contribution that I see, the pulse morphology ICP wave. So with that, I hand it over to you, Professor Colombari. Thank you, Carlos Bremer. Thank you very much for your introduction. I would like to emphasize once again how grateful I am to be part of the organizing committee and being a speaker now, especially because we started our collaborations with Brain for Care, which is a startup that developed the methodology and the technology based on the science developed by Professor Sérgio Mascarenhas. It has served as a key input because it helps us understand cardiovascular physiology, hypertension models, but also how the brain receives modifications and abnormalities caused by diseases such as hypertension. I'm going to talk about intracranial pressure and hypertension. It's a study that we carried out in our lab, published last year in hypertension. This is the group of writers and scientists with Gustavo Frigieri, scientific director of Brain for Care. He brought the idea to our lab and said, why don't we start quantifying intracranial pressure using non-invasive method? And since then, we started studying, and this study generated a master thesis of Marcos Vinicius Fernandes and the end of the PhD studies of Mariana Russo Mello. So I'd like to thank all the co-authors of this work, and I'm going to share with you a brief summary of what we observed in our study. I don't have, of course, to characterize the intracranial pressure monitoring method, so invasive method here, as described by the other speakers. There are a number of negative factors such as the risk of infection, difficulties of monitoring, and there is the non-invasive ICP monitoring method developed based on the studies of Professor Sérgio Mascarenhas, developed together with Brain for Care. This is a study published by Ballesteri et al. In 2017, which show us the technology used. And this is what we replicated in our lab in animal models of hypertension. What is the importance of intracranial pressure? The curve morphology of intracranial pressure shows us a correlation with physiological situations, and it also gives us a number. P2P1 ratio can be used as an input about brain compliance. Whenever there is P2 over P1 ratio, measured by intracranial pressure waveform, regardless of not producing an absolute number, but the morphology, the waveform will lead to some conclusions about P2 over P1 ratio. And when P2 over P1 is greater than 1, it is a warning sign to situations that may really impact the health of patients. During our study, we developed in animals hypertension, which is constantly studied by us and very well known in the literature, which is renal vascular hypertension. During renal vascular hypertension, what is intracranial pressure? In addition to the changes resulting from renal vascular hypertension, we also observed impacts on morphology of ICP pulse waveform. And based on that, we've made some inferences concerning compliance. The first experiment was to study time course variation of ICP from a dynamic perspective using invasive and non-invasive ICP monitoring methods during development of renal vascular hypertension. Hypertension development may lead to intracranial pressure modifications, and it has impact on the patient's health. One important mechanism for developing renal vascular hypertension is the involvement of renin-angiotensin system. So angiotensin 2 type 1 receptor, which is a type of receptor that triggers renal vascular hypertension. Renin-angiotensin system is really important to maintain our hydroelectrolytic balance, cardiovascular system, blood volume. But when the system works intensively, it's going to cause in our body some adaptations, which will lead to the development of arterial hypertension. In addition to that, we checked the integrity of blood-brain barrier during renal vascular hypertension development. Our hypothesis is that ATA1 receptor drives blood-brain barrier disruption, primarily important cerebral areas for autonomic cardiovascular control, leading ultimately to hypertension. Let me very simply describe the design of our study. We used Holtman mice. They were submitted to surgery to place a clip. It's placed in the renal artery. The other kidney works normally. The clip kidney will have an obstruction and a reduction of blood flow to the kidney. Once there is a reduction of blood flow, then the body is in hypotension, hypovolemia, activating angiotensin-renin system. We observed the mice for 6 weeks after placement of the clip. So animals developed hypertension, severe hypertension, as we are going to observe in the results. The first finding, using non-invasive sensor, we measured arterial blood pressure using telemetry implemented in abdominal aorta of the animals, and we monitored continuously the blood pressure, and once a week. So here we have the week divided into 6 weeks. We measured once a week the wave form of ICP using a non-invasive sensor developed by Brain4Care when used in animal experiments. The same principle as used in humans, but we just adapted that for animal trials. So considering the waveform in week 1, after clipping the renal artery, P2-P1 ratio was normal. The waveform very close to what would normally expect, and P2 over P1 ratio was below 1. And we can see through the graph all the different points in which P2 over P1 ratio was changed as hypertension came into the animals. On the right, we have the variation of mean arterial pressure starting from week 1. So high pressure, second week higher. As of the third, blood pressure was considerably high, differently from weeks 1 and 2, and showing a level of hypertension which was maintained throughout the 6 weeks. The mean arterial pressure was as high as 200 millimeters per mercury, which is severe hypertension. And P2-P1 ratio increased progressively and then got stabilized at a very deleterious condition. Here on week 3, we can see P2 over P1 ratio 1.01, showing here higher P2 and modification, brain modifications, which were quite significant. Here in the sequence, we can see the same experiment, but then using an invasive sensor. We wanted to compare the pressure variations during development of hypertension in animals submitted to an invasive ICP monitoring. So animals had to be anesthetized before experiments. We anesthetized them with urethane and then documented arterial pressure directly and monitored intracranial pressure using an invasive method. ICP measured in millimeters of mercury was normal, close to 10 millimeters of mercury. As of week 4, there is a great difference between those that had renovascular hypertension, showing ICP greater than 15. And on week 6, ICP was even higher, greater than 20. P2-P1 ratio was affected on week 4, measured through a direct ICP or invasive ICP method, showing that using a non-invasive or an invasive ICP method, the information was exactly the same in terms of P2-P1 ratio during development of hypertension. P2 over P1 ratio increased on average on weeks 3 or 4, impairing brain compliance. Next, as the method of development of hypertension dependent on renin-angiotensin system, one of the agents normally used to treat hypertension is losartan. Angiotensin 1 receptor inhibitor. It is widely used in patients with hypertension. So the same experiment was run, but then we administered losartan to the animals and observed blood pressure and intracranial pressure using invasive method. Animals with hypertension So 2 kidneys, 1 clip, had increased blood pressure. Treated with losartan, there was significant decrease of hypertension. Acute losartan, it released, it normalized pressure. And losartan also improved intracranial pressure. The animal with hypertension had ICP of 20 after treatment with losartan. There was a significant reduction of ICP. Showing once again here the waveform of ICP before treatment with losartan, P2 over P1 ratio of 1.04, and after treatment with losartan, there was a significant improvement of P2 over P1 ratio, going down to 0.82. It shows that treatment with losartan improves systemic blood pressure and intracranial pressure control, especially concerning brain compliance. There are many clinicians and people from a cardiovascular perspective which are saying, well, if you brought down the pressure with losartan, of course, ICP would go down as well. The referees asked that question, and we've run some experiments showing that losartan brings down systemic pressure and also improves brain compliance. We repeated the same study, but rather than losartan, we administered hydrodialysine, which is an important agent widely used as well. And hydralazine was very effective in bringing down the blood pressure of the animals. Mean blood pressure of 170. After hydralazine, it went down to 114. ICP used to be 15 and remained the same, and it even increased a little bit, showing that bringing down systemic blood pressure does not necessarily impact intracranial pressure. Because of impacts in microcirculation, that chronic exposure of angiotensin II caused to the brain microcirculation. Here we have a compromise of ICP due to the exposure of the systemic hypertension and also the constant activation of the receptor in the brain microcirculation. So not all vasodilators will be effective in simultaneously bringing down systemic and intracranial pressure. This is an important discovery because it has shown here as conclusions. Blood-brain barrier has a breakdown point, which was shown by this paper. I won't have time to show you, but if there's time, we can address it later. In the 3rd to 4th week, there was the rupture of blood-brain barrier. And that's exactly when there was a greater elevation of blood pressure. There was also a difference in P1 over P2 ratio, showing that intracranial pressure is affected and has caused changes to its waveform. In any situation such as this, there is a loss of brain compliance and activation with losartan 81 receptor brings down blood pressure and also improve brain compliance. So that was my main message to be shared with you today. It's an animal model, an experimental study, but it shows and reinforces the technology used and all the treatments that we are discussing here. I would like to thank UNESP, my organization, Brain for Care, which has been supporting us continuously, regardless of the result. They are always there supporting development of science as it should be done. Also the funding agencies, and Marcos and Mariana for the work they have developed. Thank you all very much. And now I'm ready for questions, discussions, or to carry on with the symposium. Thank you very much.
Thank you, Professor Colombari. Great talk. And I am working very close to that topic, and this article is been very hot at the hypertension. So let us know a little bit more about the emphasis at hypertension and why is that so? Well, that study took around 1 year to be accepted by the publication. And after that has been accepted, it was so hot. And now it's close to 1,500 downloads. So it's been very positive. And there are several websites which disseminate knowledge and made that very evident. And the publication, the journal made that open access. That is a very important publication in hypertension. But the main factor here is that losartan, which is a AT1 angiotensin 2 inhibitor that is widely prescribed, and the concept that it increases cerebral perfusion and the relationship of P2, P1, improving compliance. That is so important, but not well known, neither in the basic research nor in clinical trials. We could tell that it would improve, but we couldn't quite know exactly why. So that is a watershed showing the efficiency of a non-invasive methodology to an invasive one, and also the pharmacological treatments that we may have to improve a condition of a disease like hypertension, which affects around 30% of the worldwide population, and that represents a death factor due to cardiovascular issues. It was a wonderful presentation, but before I give you the floor as a coordinator, I'd like to make one final comment. And Professor Sérgio, he was active until one day before he died. He even called saying that he had some important ideas, and he was 78. He's so inspiring, isn't he?